There's always this awkward moment at the beginning when we wait for the room to fill up. Stare at the screen.
I can't actually see anything happening.
Okay. We'll just give it a moment. It always takes a little while. Just waiting for the numbers to bottom out. Okay, I think we're there. Well, good morning, everybody. Oh, good afternoon, everybody. I'm really pleased to welcome you all to this, the latest in our lecture series. I'm really delighted to have with us today Isabella Myers, who is the chair of the CO, the COMED group, which is the medical and healthcare subgroup of the all-party parliamentary group. Izzy is an air quality specialist, formerly of the UK Health Security Agency, which was PHE, and Health Protection Agency before that. She's here today to talk about a piece of work that has been going on for a while, for one reason or another, that looks at the coronial setting in England and Wales. The project started in 2017. Initially, there was a pilot which was going to look at a protocol that coroners test routinely. Because of the legal framework that the coroners work in, that wasn't possible. So we looked again, and during that period, the government announced the introduction of the medical examiner's role. This meant that there was an opportunity for us to better understand how we collect data. It's taken a little while for that role to be developed so that this piece of work could happen. And finally, we're in a position that we can release the report today, and Izzy's here to talk about the findings and the outcomes of that piece of work. Before we get started, I'd like to thank Isabella for doing the work and being patient beyond belief, really, to keep going, you know, regardless of the barriers and the challenges that we've had along the way. Thank you also to Roland Vessling, who through Cranfield supported this piece of work, and to Baroness Finlay, who hosted a parliamentary roundtable, which also fed into this work. But anyway, enough from me. Let's pass you over to someone who really knows the ins and outs of this work. I'll hand over to you now, Izzy. Thank you.
Excellent, Adrian, thank you. Let me just get my screen up. This lecture is the medical examiner. Could the introduction of the new role change the face of carbon monoxide safety?
Izzy, you haven't shared your screen.
Oh, sorry.
So this piece of work was prompted by a recommendation that
Hold on. Is it sharing now?
It is, yes.
Right.
this lecture is the medical examiner. Could the introduction of the new role change the face of carbon monoxide safety?
Sorry, there's something that's gone wrong.
Natalie, do you want to share it from your screen?
Yeah, no
please?
problem.
My apologies.
Don't worry.
This lecture is the medical examiner. Could the introduction of the new role change the face of carbon monoxide safety? So this piece of work was prompted by a recommendation that came from the first inquiry undertaken by the all-party parliamentary CO group in 2011. So in 2011, the group identified a key role for coroners to support the increased detection of carbon monoxide poisoning in England and Wales. And their report recommended that the government should ensure that all coroners' post-mortems routinely test for carboxyhemoglobin levels, recording death from carbon monoxide poisoning as a distinct category, and to notify this to a central register if a verdict is recorded only in the narrative section of the coroner's certificate. So In 2011, this seemed a reasonable recommendation to make amongst the stakeholders that were involved in the inquiry, as the science at the time was suggesting that lower levels of carbon monoxide could be implicated in many more deaths than actually expected. But there were still gaps in our understanding, and a need for more evidence to clearly develop the picture and build a case that might enable this recommendation to be taken forward was still actually required. And so the work of the APCOG and others, obviously, continued. CO stakeholders took forward other recommendations within the report. They looked at research and initiatives, and these were continued or were developed to improve working practices and developments in technology, understanding the complexities behind behaviours that resulted in CO exposures in different locations. In 2017, COMED published a report that considered the medical and scientific implications and experiences of exposure to CO. And this really did highlight, again, the impact that relatively low levels of carbon monoxide could have an effect on health. And also there was a difficulty with diagnosis. And it also sort of covered environmental health, clinical toxicology, poisons information, and experiences from paramedic practice, emergency medicine, et cetera, et cetera. So gaps in fundamental research were put in, and some of those gaps have since started to be filled. But essentially, it highlighted the effects that exposure to CO was having on patients' health. Now, the home has long been acknowledged as a notoriously difficult place to regulate. And when the opportunity arose to update the regulation pertaining to CO alarms, evidence from the APCOG and many other stakeholders assisted in what has resulted in a positive change. However, 10 years has passed since the recommendation was made by the APCOG, well, 10 or so years. So really, where are we now with this? Well, I'm going to prolong the agony a little bit, just because last month, Ewan Sandilands from MPIS provided some data in his lecture, which of course I highly recommend you watch, from a recent study. And this highlights the continued problem of exposure in people's homes. It really emphasized the issue that people who do attend hospital, because his figures were looking at that, are exposed to CO in their home from faulty appliances. And for me, it really actually prompted the thought that people who do not attend hospital and who have symptoms, but might think that they perhaps have flu or that they're just symptoms of pregnancy, getting a handle on those figures is actually far more difficult. And Ewan also highlighted, this is a slide I've sort of taken from him, it showed the source of exposures that were identified in his study. And none of these appliances are in themselves particularly remarkable. And they're not just fueled by gas, just to note, but include solid fuel. But Ewan's talk has sort of, in this instance, helped me to build the picture around the work that has been undertaken on how best to achieve the recommendation that was made in 2011. And it really builds on what we know and the changes and developments that have occurred over the years. So this might not be a new slide for many of you, but they're really useful gas industry figures that provide us with some feel for risk. If someone does actually get their appliances checked, they should employ a registered engineer to do so. And a registered engineer is one who, by law, is allowed to undertake gas work. But industry has established that this is often not the case, and their study looked at the functioning of appliances in homes that had used illegal gas fitters, including those that are sort of avid DIYers. And these are the results. You can see that 3 out of 5 were found to be unsafe, and 1 out of 5 were deemed to be immediately dangerous. So it is, it is also important to realise, so even though we have, I can't use the pointer, these 3 out of 5 to be unsafe, it really does make us remind us, that carbon monoxide can also move through the walls and floors of terrace houses and blocks of flats. And therefore the CO that affects you or your patient may actually have come from a neighbour's appliance. So you could see, this is quite a good diagram where you can sort of see how the idea is that one boiler, which is deemed to be dangerous enough to be immediately disconnected, could actually spread to the neighbouring house quite easily. And there are over 23 million households or premises in the UK that use gas. This is another figure from the Gas Safe Register on illegal installations, and this highlights the issue further. And despite the gas and other fuel industries trying to stamp out illegal work, they showed that there are still many thousands, hundreds of thousands of installations taking place each year. So if we look at the space that people call home, this varies greatly. And some of us might not even consider some of these places a home. Preventing exposure to CO in the domestic indoor environment is largely left to the occupants or the owner of the home, although regulation and legislation exists across many different government departments to ensure and to promote the safe use of gas and other fossil fuels, and obviously the prevention of CO poisoning. But despite this and the awareness campaigns that go on, accidental deaths from CO poisoning still occur. The difference, obviously, with places of work or public spaces are that they are regulated. And while CO exposure can still occur in these places, the risk is reduced and action can be more easily taken on those responsible for malpractice, whether exposure to carbon monoxide in these circumstances has been fatal or not. However, the home is not completely unregulated, and where possible, these standards, regulations and acts are utilised to protect the occupant from harm. So if we look here, we have the Decent Home Standard, which even as recently as August 2018, published a green paper, a new deal for social housing, to seek views on whether the Decent Home Standard sufficiently covered issues relating to safety measures in social housing. And this included issues that pertain to CO exposure, and this review is ongoing. Also to note that the Decent Home Standards is looking to be rolled out to include the private rented sector, but this is still to be confirmed. Another act, this act, Homes Fitness for Human Habitation, actually came into force as recently as March 2019, and this lists CO as a pollutant of concern. However, there is a caveat, because whilst CO exposure makes a home not fit for human habitation under its lists of hazards, the caveat is that the landlord will not be liable where the problem is caused by the behaviour of the tenant. So think about the behaviours report by the APCOG, or by if the problem is caused by the tenant's own possessions. Now, this is also tricky because in a number of circumstances, the tenants may, for example, own the gas stove. So gas safety legislation is also found in the building regulations, where there are factors to prevent or to alert to the buildup of CO. Gas safety legislation for the workplace is vast, and there are sections of it that then also apply to domestic gas. And at a global level, there are also the World Health Organization's indoor air guidelines, and these are set to protect health, and CO is included in these. So Having considered the risk factors, it is reasonable to presume that healthcare professionals identify carbon monoxide poisoning exposure on probably a fairly frequent basis. But healthcare professionals actually rarely consider carbon monoxide, and exposure is not considered a common occurrence. And this is why the figures seem quite low. But part of this is likely to be due to a lack of correct diagnosis. It is widely accepted that the recorded incidence of deaths that result from acute high levels of exposure to CO are actually accurate. And that we see a declining trend actually provides some comfort, I'd say, that the awareness raising and prevention strategies are working. But misdiagnosed or undiagnosed carbon monoxide exposure in the living can result in the patient being returned to the environment where poisoning occurred, dying, and the death perhaps not being attributed to carbon monoxide, but to some other health factor. So what is crucially missing is the suspicion of CO exposure by the healthcare professional. When you're juggling with symptoms that mimic other seemingly more common illnesses, and you have a patient that's perhaps presenting in settings that might not be conducive to the consideration of the home environment, is clearly problematic. So the key to correct diagnosis is a high index of suspicion, and there the danger is when CO is missed. In those patients that have an underlying health condition, they are likely to be seen by a specialist and their condition managed accordingly. However, the worsening of a condition is not necessarily, should we say, alarming to the specialists, as many conditions can deteriorate due to season and, especially the cold winter. This is a time when people stay indoors, decrease their activity, and when there is less window opening. So a season which, of course, ties in with the increased use of heating appliances. So whilst these factors can contribute to the worsening of disease, it can also increase the duration of exposure to CO. Unfortunately, with such a focus on the health condition itself, the suspicion of CO being a factor in a worsening a case where the disease is worsening is probably unlikely to be raised in the healthcare professional. So if the patient appears well but is older, a trip and a fall in the home would not necessarily raise suspicion of CO exposure, with the consideration being perhaps whether the medication that the patient could be taking was causing dizziness, or perhaps whether the patient had had a stroke. However, it is clear that lower levels of CO can trigger a cascade of what you'd call pathophysiological effects, leading to death, particularly in those with a comorbidity. The state the patient is seen in has also to be considered. If the patient cannot be questioned, then examination and information from others are really important. Now, you could imagine that the patients come into, say, the ED department, or perhaps it happened in the home. These are important for many different reasons, because there are literally so many causes for collapse or unconsciousness, and of course death. But again, it's very simple from our perspective to understand the need to consider CO. So in layman's terms, what we note is that the question that the 2011 APCOG report was really asking was, did the patient die from CO poisoning or with CO poisoning? Did chronic exposure to CO bring forward the death of the patient with an underlying health condition? Did chronic exposure accelerate the decline in patient health? Or did it even perhaps trigger the onset of disease? If any of these were the case, then investigation based on the regulatory and legal frameworks associated with, for example, gas use and carbon monoxide, it's required. And with this in mind, appliance engineers actually are more likely to, as it were, diagnose CO exposure within the home environment when servicing an appliance or called away to an emergency than a health professional. But exposure in the patient is not hard to diagnose in either those living or those who have died, as a measurement of carboxyhemoglobin can be made. Carboxyhemoglobin remains fairly stable in blood, which is important for those that have died. It also remains fairly stable once collected from living patients, but it does have a half-life of 4 to 6 hours in those breathing non-polluted air. However, as CO is classified as a poison, and therefore any suspicion of CO being implicated in a death, a referral to a coroner has to be made. There are a number of situations where deaths are referred to the coroner, and I'm not going to go through them all here. But currently, about 45% of deaths are referred to the coroner, and these referrals occur either because the cause of death cannot be determined, or because the death falls into a category that requires referral by law, such as exposure to carbon monoxide. And I think really here we can see that the top 3 on this list are those that relate to circumstances where carbon monoxide exposure could be implicated. However, in 2019, there were a few additions made to the Coroners and Justice Act of 2009. This update states where there is reasonable cause to suspect that the death was due to, that is, more than minimally, negligibly, or trivially caused or contributed to by the following circumstances. And I've picked out one of these circumstances, and this is neglect or self-neglect. But I think this is important to note because neglect in this context applies to the neglect of the deceased if they were in a dependent position. And that there was some failure or omission or delay in the provision of basic and obvious requirements to the deceased. So examples provided actually include adequate warmth and medical assessment. So just to note that. There's also under neglect, there comes this other bullet, which is where a death, although from natural causes, it would be reasonable to suspect that the death resulted from some human failure, including any acts or omissions. And then the third bullet point, where the death of the dependent occupant is due to the natural progression of an underlying illness, but where death was accelerated due to neglect by others. And so questions around the death in the home start to be raised. And you could imagine, I just picked these really off the top of my head, has the exposure occurred as a result of poor engineering workmanship, or as a result of a community healthcare worker not recognizing the implications of reports of an alarm sounding occasionally by her patient or his patient, a carer using an oven to provide warmth, or a friendly neighbor helping out with appliance maintenance. So, in this situation, could the coroners help? So yes, is really the answer. Official figures from the cross-government group on CO and gas safety are provided on an annual basis on accidental non-fire related carbon monoxide deaths. They use the International Classification of Diseases 10th revision, the ICD-10, and here deaths are selected where the underlying cause of death was accidental, and accidental deaths are listed between V1 to X59, and where the secondary cause of death is the toxic effect of carbon monoxide, and this is ICD-10 code T58. So for the underlying cause of death, we pick out X47, as this is a category for poisoning by gases and vapors. And these are broken down into then places of exposure. So you could have X47 point anything from 0 to 9, which will indicate where exposure occurred. And the home is one of those. And T58 is a toxic effect of carbon monoxide. And we have seen, as I said, the number of deaths decrease over the years. And in around 2011, when the report was, the APCOG report was produced, we were looking at around 50 deaths a year. And now it's down to around 30, perhaps even 25. But it is important to remember that these are not numbers. These are people who shouldn't have died. It was an accident. And whilst we think that these figures are accurate, those where CO has not been implicated because the levels have been perhaps considered too low, or there has been underreporting, then this is not good. So this is what was picked out by the 2011 report. And when we look at the way that CO is recorded, it's important to remember that to test for CO, the coroner actually has to have a level of suspicion that CO is implicated in that death. So this is where the recommendation in the 2011 report became tricky, as whilst coroners are able to request an autopsy on the deceased, the coroner must have reason to suspect that the results of this autopsy will reveal evidence that will facilitate and actually establish a cause of death, either an underlying cause or a contributory cause. So this makes a specific coroner-wide mandatory request for routine testing in all deaths for CO unlikely to be accepted in England and Wales. So for the coroner, traditionally the results of tests for high concentrations of carboxyhemoglobin in post-mortem blood would need to be high to confirm poisoning as an underlying cause of death, that X47. But lower levels of, but still raised levels of carboxyhemoglobin could also be probably attributed to tobacco smoking, or perhaps a death in the early stages of a fire. So a development in the scientific understanding of the effects of lower level exposure to CO on, for example, the cardiovascular and neurological systems has meant that the identification and consideration of carbon monoxide at post-mortem, where lower carboxyhemoglobin concentration than has historically been considered necessary, is actually now important. However, questions still remain. Whilst we've picked up this important point, how was the referral to the coroner to be prompted to incorporate this lower level of poisoning from carbon monoxide? And in April 2019, NHS Improvement started to roll out a national programme to introduce a new medical examiner role at all hospital trusts, and their job was to provide independent scrutiny of all deaths. The purpose here is listed on the slide, and to provide greater safeguards to the public, but where we're concerned, also to ensure the appropriate direction of deaths to the coroner, to provide a better service for the bereaved and an opportunity for them to raise concerns to a doctor, to improve the quality of death certification, and to improve the quality of mortality data. So it was understood that the role would eventually be rolled out to the community, and that this had the potential to close the loop that was allowing death to continue from lower but significant levels of exposure to CO, and to protect other occupants and to improve mortality data. So what is it about mortality data that is so important? It provides us with clues as to what caused the person to die. It helps us to understand, along with figures of birth, the size of the population. But it's the granularity of the data and analysis of the data that will actually help us understand what caused the medical issue that resulted in death to occur. And when you link this data with other data, such as data gathered from investigations requested by, for example, the coroner, and for data that's perhaps, say, linked with alarm data or appliance engineer servicing data, this is where when you can really start to develop insight. And really, it's this insight that really then helps to develop appropriate interventions and processes to prevent future incidents occurring, or to improve knowledge on cause and effect, and obviously to help develop research. And improving knowledge on this known and very silent killer, and by being able to provide evidence through better CO data collection, is really important, because this data is also used to inform practices and policies at a local, regional, and national and global level. And the analysis of such data also informs the funding for healthcare development and research. So even where CO is listed as a contributor to death, and the death is not recorded as a CO death in its own right, this information is still of vital importance. At the moment, data on CO exposure is collected and stored by individual stakeholders. And the report acknowledges that technologically, by not having a decentralized database to be able to capture information on exposures recorded by the many different stakeholders, actually seems quite at odds with technological progress as we see it today. So, going back to the recommendation, the APCOG identified this key role for coroners. And it's true, there is a key role for coroners, but importantly, there is also a very important role for the new medical examiners to support the detection of CO. In July 2019, Baroness Finlay kindly hosted a roundtable event to provide the opportunity for a group to discuss ways to ensure that medical examiners and coroners do not overlook CO as a cause or contributor to death. And discussion that day was based on the scientific, healthcare, and industry sector evidence that suggested that the prevalence of CO exposure is much larger than the current figures imply. There was also discussion on the effects of CO on the fetus, and the very sensitive discussion on coronial investigations in babies and the ongoing consultation on coronial investigations into stillbirth in light of CO exposure being identified by midwives at first booking appointments, and the well-known risk of CO exposure and its effects on the newborn. So, the recommendations and actions that came from this investigation. There were 18 recommendations in the main report, but all very valid. Generally speaking, these recommendations point to a more holistic way of working across government and stakeholders. Guidance and training and technological development were key players in making this system work where we can then close this loop. And new ways of sharing data and improved analysis were required. That's just generally what the recommendations covered. The roundtable event also produced recommendations which fed into the main report. And interestingly, though, I also felt it was necessary to include many separate actions that were listed from the roundtable to develop understanding across midwifery and appropriate messaging to mothers-to-be. Also from the roundtable event, and a very important point about joint working with other CO stakeholders with regards to midwifery and mothers-to-be to help them understand the very sensitive nature of baby death. And this was very important. So what have we learned in terms of the main messages? Firstly, I think that, and I would say this, I expect, but research that court is funding is having a very positive impact. The CO Research Trust has enabled this work to develop in a timely way, alongside huge changes in legislation and regulation that could not have been believed practically when Recommendation 7 was developed in 2011. So over this past 10 or so years, the CO Research Trust has continued to fund research that has then also contributed to the evidence required to make a change across all CO stakeholder sectors. And this actually includes the research that has supported pieces of this work as it too has developed. The identification of a gap in current regulations and legislation is important. And this absence of a joined up approach between accepted and developing scientific knowledge, medical diagnosis, coronial investigations, and the regulatory and legislative requirements of industry and government departments, has created this loophole. And it's this loophole that actually perpetuates illegal gas work, allowing this work to take place because it doesn't necessarily cause death, it just causes gross morbidity. And it also produces, therefore, a lack of accurate reporting of CO poisoning related deaths in the community. But of course, being able to identify how to close this gap is unquestionably positive. The medical examiner has the potential to play such an important role in the prevention of deaths where CO is implicated. And their work is likely to contribute to an improvement in public health. And I think ensure that England and Wales can develop the measures required to protect its population from accidental exposures to environmental CO. And just lastly, really on a positive note, the intention is there, there is acceptance that this work needs to go forward, and that actions now need to be taken. But from my point of view, it really must not take another 10 years. Thank you. And I would just like to acknowledge the support of Roland Wessling from Cranfield University, the CO Research Trust for funding the work, to Baroness Finlay for hosting the roundtable, and to Professor Bob Flanagan, who allowed me to call him and ask random questions on many occasions. So thank you. And also to those that attended the roundtable, where we really had such a good discussion. And I'd like to thank all of these people for attending and for their time and support. Thank you very much.